For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up, Season 4, Episode 24 of Surfing the NASH Tsunami. Our review of last weekend's Innovations in NAFLD Care Conference in Barcelona starts now.
This week on Surfing the NASH Tsunami.
We were trying to look at the liver a bit more holistically and look at who else should be involved in a multidisciplinary approach.
Very special, unique, new feature was actually the hands-on training and an NIT summit that was not, to educate hepatologists, but to educate people that have not come into contact with NIT so frequently and provide a learning platform.
Everybody should know two numbers about their liver fat and their liver stiffness.
To use Stephen Harrison's phrase, this is a canary in the coal mine, but really what we're trying to do is we're trying to improve health in the coal mine, not just worry about the canary.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join hepatology researcher and key opinion leader Professor Jörn Schattenberg, liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and their guest, public health and hepatology researcher and key opinion leader Dr. Jeffrey Lazarus, as they review highlights from last week's second annual Innovations in NAFLD Care meeting in Barcelona on Surfing the NASH Tsunami.
So with the tip of my hat to my guest and co-host today, that Barcelona meeting looked like it had an awful lot packed into just a couple of days. And Jörn said he wasn't going to comment on the after hours, so I will only briefly and say that having been at this meeting last year, I know that the after hours are a part of the event. And nonetheless, Jörn and Jeff Lazarus are both here with us today, both looking more or less awake, although, Jeff, your eyes look like they may be just a tad tired. So at any rate, let me welcome everybody. Jeff, thanks for joining us today, and congratulations on a successful meeting.
Well, thanks for having me, and congrats to Jörn and everyone. We had 25 faculty.
Jörn, congrats to you for a successful meeting as well.
Thanks. And again, I can only accept this on behalf of the organizing and steering committee. I think we've seen strong commitment on all sides, and it's with the faculty we have, I expect it to grow further.
Fantastic. And then Louise, welcome back to Northern Hemisphere. A simple podcast today. We're going to review what happened in the Barcelona meeting. Jeff and Jörn will go through it session by session. I caught most of it. Louise caught a bit of it. We will have questions as we go along, and that should do it. And that should take us the time that we have allotted. And I think it'll be quite good, because if we have extra time, I have a couple of stimulating related topics we can get into, so we should have some fun. With all that, simple groundbreaker, one good thing, personal or professional, that's happened in the last week. Bonus points for Jeff or Jörn if you could choose something that's not about the conference. Brave one, go first.
I will go first. After the conference, I went out and met my team who was testing for biohepatitis in the community in a religious ceremony being held in an abandoned warehouse. And from there, I climbed a nearby mountain, Montserrat. Well, I took the cable car up and walked down.
But Jeff, walking down is tough for the bones. Walking up is good for the heart. So next time, I'd hope you'd do the other way. Although I don't know what type of climb that would have been, so I can't say much about it.
I'm trying to visualize what a cable car down looks like. It can't be nearly as much fun as a cable car up, but that's for another day. So Jörn, now that you've been bold enough to comment, why don't you go next?
I'm back from Barcelona. Unfortunately, I couldn't stay with Jeff. It's been an extended weekend too. We had the Pentecost weekend here. It's actually school holidays. Personal highlight, if I look out of my window, I see the kids running through the lawn sprinkler. So that's kind of amusing. It's nice here. And again, I'm full of energy and positive thoughts. Thinking back of the 2 days we spent in Barcelona for INCBCN.
So in the one football comment I will make today, Mainz is living today somewhat in fame, except in Dortmund where probably infamy, because all Dortmund had to do was beat the lowly Mainz football club and they would break Bayern Munich's 10-year hold on the Bundesliga. But in fact, Mainz scored 2 goals in the first 24 minutes, held on for a draw, and Bayern Munich won the championship again. Tears and devastation all over Dortmund.
You're right. You're following German soccer much closer than I am. It's a strong team. It never makes quite the top, but it prevents Swiss descent, so I think they're somewhat famous by now for certain things like that. And of course, for producing Jürgen Klopp and also Thomas Tuchel.
That's true. So great coaches come from Mainz, Jörn. Those of us who work with you know that already, but now we're learning about football as well. Louise, what you got?
Osasuna of Germany. Osasuna that made it into the finals with Madrid and yet outside of Spain are barely known. They beat Barcelona 4-0 a few years ago and then lose to everybody else.
So they have their moment, but this year is not Osasuna's moment. It is Mainz's moment. Okay, Louise, what you got?
I suppose it would have to be getting back from Perth yesterday morning at 5 o'clock British time to then play 18 holes of golf, probably better than I play 18 holes of golf when I'm actually not jet lagged. So I'll take that as my win for the week and my 21,000 steps for getting off a plane, having been on it for 17 hours. So it got me less stiff, but and it helps you sleep. So I'm very happy.
Well done. The one thing I've been told about playing golf tired or even, frankly, hungover is that the slower you swing your club, the more likely you are to hit the ball cleanly. So if you were so tired that you swung in slow motion, that might have been good for you, eh?
Definitely.
I guess my highlight is just that we went through Memorial Day weekend, and Memorial Day weekend is not a happy weekend in the States. It's a weekend that we, as much of the rest of the world, commemorate our war dead and the ultimate sacrifice that they made. If Stephen were with us, we'd have a longer conversation about this. But it did allow me to spend an afternoon splashing around in the pool with my granddaughter and probably over the course of the weekend to see 4 or 5 dozen friends in different settings. And that was all a good thing. And I think enough of a good thing. So with that, why don't we shift? INC2. We talked about it in the preview, but just to set this up for anybody who might not have been to the preview, Jeff and Jörn, I'd love it if you take a minute or two before we start, talk about what you're hoping to achieve this year and how it was different or similar from what you looked to achieve in last year's meeting, just so folks who did not hear either one in person or in real time have context for the rest of the conversation.
Okay, well, one of the goals this year was really to expand the community of practice. So we wanted to engage more with endocrinologists, more with primary care, again, with patients as well. Last year, we had a whole patient roundtable, and this year, uniquely, we had an entire endocrinology session. And I think that was an important difference. We also wanted to start in thinking about new concepts like preventive hepatology. So not just preventing those with liver disease from advancing to cirrhosis or HCC, but also primary prevention. So we were trying to look at the liver a bit more holistically and look at who else should be involved in a multidisciplinary approach.
So we'll come back to preventive hepatology because I thought that was actually one of the more interesting short exchanges of the first morning of the conference and was around that topic. So that's great. And I thought the endocrinology session was fascinating. And as you point out, different from last year.
Yeah, let me add in. I think this is the second time. So we were both anxious whether it would draw enough attention again and see the participation and whether it could live up to last year's expectations. And I say I was taken away how well the comments went this year. So overall, I have a very positive feeling leaving Barcelona. One of the learnings was that we wanted to include some practical hands-on sessions. And for that, when we designed the program, Jeff and I were thinking how that could have been achieved. And I think for me, a very special, unique new feature was actually the hands-on training and an NIT summit that was not, to educate hepatologists, but to educate people that have not come into contact with NIT so frequently and provide a learning platform. And I think moving forward, this is one of the parts that we really want to expand and broaden. Again, I got scanned during the NIT summit. I have a 3.3, Louise, and I think it was, I forgot, but I think it's below 200. That's maybe wishful thinking. But anyways, so you can get scanned, you can scan, and you can just make experience with those NITs, which is urgently needed. And I think the NIT summit is a good platform for that.
So how many folks attended the NIT summit?
We were probably 60 people or so, including a handful online. Obviously, they weren't involved in the hands-on training. A lot of people go to the meeting who are hepatologists and who have seen a FibroScan. So I was happy to have that kind of numbers. Also because it was really hands-on and there were only 2 FibroScans, there couldn't be that many more people. So I think it was good. We had a couple people from my team who spoke with EchoSens and are going to be able to borrow a FibroScan ticket into the community. Because, one of the things is when we're working on biohepatitis, and, I have a long history with hepatitis C elimination efforts, we don't FibroScan in the community. It's harder. I mean, we have to get it there. We need more privacy. It's slower, but we don't do it at all all. And so that's something we want to change. And I think it was a real eye-opener for many people who have never seen a FibroScan, have no idea how it works, didn't even fully comprehend what it meant. Little by little, this is how we start to change the field, the same way many hepatologists who work in clinics have never seen rapid diagnostic tests. They've never seen an HCV antibody test. They've never seen a dried blood spot card and so on.
I thought that was fascinating, and it's fantastic. How did people react? One of the biggest points for me in FibroScan is actually how people react to having one that's different to a blood test. So, Jörn, you do what I would like everybody to know. Everybody knows their blood pressure. Everybody should know two numbers about their liver fat and their liver stiffness. So 197 and 3.3 or something like that, so that you know where you're going in the direction. It's excellent to have people do hands-on training, but it's also important to say that you've got to be supervised for a number of scans after by a highly experienced person to make you proficient in fibroscanning. It's more than just doing the hands-on. And I am more than happy to give a master shot work class in fibroscanning in the community, having done it from yachts to hotels to seaside resorts to all sorts of places. We focus on community scanning, and it can be so much more engaging for anybody who's being scanned, and particularly more difficult to reach populations. So it's a fabulous thing. So what was the feel when you had your 3.3, Jörn, and your normal fat content?
So it was actually my first scan. I, believe it or not, never got one. I think I did one myself standing up way between the door and the machine, which is not a valid scan. So it's nice to get a number where I would have hoped for that result, but then you never know, right? And until you get scanned. And that's this history that Jeff knows from also infectious disease. Get tested. And get ruled out.
I think that's key, because I know a number of doctors with NAFLD and some fibrosis, and we're not the healthiest people, although we talk health. So it's always interesting. Jeff, did you get scanned?
So I was actually scanned 2 weeks earlier in Odense, Denmark, when I was visiting Alexander Krau and Maya Thiele. I was giving the opening talk when she became a professor, and they gave me a nice tour. They fibroscanned me with the whole unit around, and coincidentally, I was also 3.3. I'm even happier knowing that Jörn, who's so thin and fit, is a 3.3. I would have thought there was something wrong with the machine, but mine was in a completely different country. But I have to say, when you're lying there and everyone's laughing and joking, for a minute you think, what if it's 9, Like, I don't know, what if it's 7? And so you worry a little bit. And then when the number comes up, you're like, oh, yeah, like you said, we can rule this out. It's something everyone should have done. They should be aware and then work to not let that number increase.
I think it's an engaging tool, as you know, but I think the funny thing is the reaction. Older people always go, oh my God, I can't believe it's that good. Younger people go, oh my God, I can't believe it's, because everybody expects the liver to age as we age, and it doesn't. So it's a great learning opportunity. It is interesting, the dynamics of lying on that table going, oh, have I made the right decision now? Knowing, even if it's not great, is always good. It gives us an opportunity, as you know. So I'm glad it was so well received.
So I'm delighted that you both had such good experiences. I'm sure you weren't as familiar, I'm not sure Jeff is, or at least has heard about my first FibroScan experience. I had very large rib cage, and this was done in Stephen Harrison's office in San Antonio right before the pandemic by one of his people. And as they're scanning me, I'm watching Stephen get greener and greener. He looks at me and says, has anyone ever talked to you about liver transplant? Dead serious. I said, I have really large ribs. You might want to have somebody else do this. And in fact, Stephen then proceeded to do it himself, and I scored about 3 point something. I forget what it was, and we all had a good laugh. But for a moment there, it was interesting.
But I think that does show that it's not just a simple test. If you get too high or too low, you're going to get a higher reading than you should. And I think you really have to be aware. You also have to look at the elastograms to know that you're in the right tissue. It's not just point and shoot, because if you point and shoot in the wrong area, you can make people cirrhotic.
Or score cirrhotic. You don't make them cirrhotic. I did not become cirrhotic. I just scored cirrhotic.
But thank God it was different.
But Jeff, that actually brings me to the point I wanted to ask, which is that the conference itself, with the ability to go virtual, you can curate it, you can keep it small, and you can have pretty broad global throw. But NIT Summit, because it's hands-on, doesn't necessarily throw as much off outside the room, would be my guess. And my question is, does it make sense to try to make that a brand and take it to other meetings as well?
Oh, I think it does. The same way, again, with viral hepatitis, RDT, rapid diagnostic test trainings. We should go around. And I'm sure EchoSense, but also other companies that do TE would be happy. There's a lot of people who can speak on NITs. We probably needed to have a slightly more beginner presentation of NITs to people. Some people really have no idea what we're talking about. You have to spell out non-invasive tests, tell how many there are, why you use some and not others. So already I'm working on a plan I'll share with you, Jörn, for next year about how that can look a little different, and then tell people, what time of the day they should come. So the beginners should come from the beginning, and those with more experience, and want to have a debate really on, cutoffs and so on, can come towards the end, and then we'll figure out if we do the same kind of training or a slightly different hands-on training.
Other thoughts, Jörn, or shall we dive into the first session of the conference, the fatal triple?
Let's move on, because I think, while this is something we want to move forward, I think there were many more unique features. And really, just for a wrap-up, let's talk about the fatal triple, which was the official opening of the workshop. I have to say, before we could even open it, we were overwhelmed by another round of music. And something that makes this workshop so special is, I guess, the atmosphere in Barcelona. That goes back to Jeff and his, having lived there for such a long time. So it was a great experience.
Since no one in this audience, unless they were in the meeting, would have heard the music, you've got two choices: explain the music or go on to the session. I'll go either way on this.
Yeah, it was a short session of flamenco. Is it flamenco music, or how would you actually call it? It's a tradition. Jeff, you're much more qualified to comment on it.
I thought Roger was going to say there was a third option, which was to actually try and sing or play air guitar. So I appreciate that wasn't requested. It's flamenco, so it's not at all from Barcelona, but since there are flamenco dancers and guitarists and musicians in Barcelona, and everybody loves that music, I asked a group that I had met last year just before INCBCN in a bar where they were playing if they would come. And it turns out they were quite well known and abroad as well. So they came back again this year and interrupted Jörn and I in the opening with their guitars and their singing. It's very tortured, from the earth, from the roots kind of music and dance. And they did about 15 minutes at lunch and 15 minutes in the opening, put us a little behind schedule, but I think it was worth it. And then we kicked off with the fatal triple like we did last year as well.
So with that, let's go into the fatal triple. Jörn or Jeff, please take us through a little bit of what was in the session and what you found so interesting about it. Like, Jörn, you were the chair. Maybe this is one for you to do.
Yeah, let me get started. I was joined by Anne Holleboom, who's an endocrinologist from the Netherlands, Amsterdam. And actually, the first speaker was Harriet Rumguy, a PhD student who works with the WHO on HCC aspects in public health. And she's actually a first author of a recently published study in the JHEP. I think it even made it to the front cover. So she was really a great speaker to kick it off and reminded us that the epidemic burden of NAFLD has led to an unprecedented increase in cancer, particularly liver cancer, but we're also seeing non-hepatic cancers in these patients. I think that was important just also to hear that the WHO or that a PhD student at the WHO is addressing these things. Second presentation was given by Ramon Bataller, a local hepatology lead or clinic head there. And Ramon has been worked on alcoholic liver disease for a long time. And of course, there's a lot of overlap. So he tried to answer or reminded us that there is no way to safe drink, but many aspects of genetics, obesity, and environment contribute to severe liver disease. If you overdo it, we would call it alcoholic. If you are, let's say, a moderate drinker, it can add to your non-alcoholic fatty liver disease. So two great topics right on that opened in our of clinical relevance. Patients end up with cancer, and how do they get there? I think it's the environment and alcohol adds to it. And then actually a fellow from my department was presenting one of these selected abstracts on screening work in diabetes and primary care practices. And actually here we found 10% of cirrhosis, or let's say 10% of greater than 15 kilopascal on FibroScan, which is not always equal to cirrhosis, but it's a significant burden of liver disease. So to me, that first session, which was ended up then with a roundtable discussion to address these aspects, started off well.
So I'll just add to that overview. I met Harriet Rumguy when I saw her article on the cover of JHEP in the autumn, and we had connected on LinkedIn. And I just thought it'd be great to have a young woman. She had just finished her PhD, open up the conference, like Jörn said. IARC, the International Agency on Research on Cancer, which is based in Lyon, France, is a part of WHO. And since they had focused on liver cancer, I thought let's get WHO into the meeting that way, even if they're not really addressing fatty liver disease at all in general in their NCD work. Schattenberg. And then, Ramon Bachet is so well known to everyone as the master and commander of alcohol-related liver disease and the head of the liver unit at the Hospital Clinic where my institute's affiliated. Ramon also introduced the concept to us of social drinking as well as careless social drinking, and he just looked up some definitions online, and it was quite humorous and quite sad because you can drink a lot in social drinking, and then it said if you have careless social drinking, it can end in death. So it went from social drinking was having a drink, or two with friends and colleagues, to careless means you socially drank too much and died. So he just kind of reminded us of the dangers of social drinking, because we often talk about, heavy drinking and refer to it differently. But when social drinking, it seems to be okay. And he reminded us that it's not always okay.
I thought one of the really interesting things about Ramon's talk was exactly how many different ways he described drinking and how many different ways he described how people assessed the quantity of what they were drinking relative to A, what it accurately was, and B, relative to some internal yardstick they had of, is it okay or not? Most of the people I know who tell me they drink a little too much never drink more than a bottle of wine in a day, but they probably drink that 7 days a week. So to me, that would be a lot more than a little too much. It's that kind of thing. I mean, everybody sets their metric where they do and then measures out from there. And I thought his talk was really fascinating about all the different ways that happens.
Yeah, it was great. He kind of reminded us, just like the Greenlanders have so many different ways to say snow, we have so many different ways to describe a standard unit. And he's been discussing with me the idea of getting some consensus around what a standard unit is. And then Henry Mark, who works with me and Iso and used to be at Wilton Park, tweeted an image. And we know Ramon is very prolific on Twitter and provides mentoring advice as well. And so Henry responded with an image of what a standard unit has looked like over the last 100 years. And it just gets bigger and bigger and bigger. So it becomes a bit of a supersize. I'm having one drink and it's the size of the big gulp.
Mm-hmm. That sounds right. And in the pandemic, in fact, it probably becomes bigger, roughly the size of a dog's water bowl for a large dog. But yeah, that I like that. I like the visualization on that. Jörn, any comments on practicality of Dr. Michel's presentation, or practically what people in the room took away from it, or you felt they were taken away from it?
Well, I think it was about outreach and going into places. I took a FibroScan into endocrinologist offices, and we didn't even have access to all the lab results. We just scanned there to broaden recognition. And I think that's, Jeff does that on multiple levels. For us, it's easier in the medical system. So we hooked up with the primary care providers there. But it's an eye-opener if you get the result that, 10% of the patients you're seeing are in a cirrhotic range. And a lot of patients and the physicians wouldn't have thought so. So I think that's the hands-on. Of course, this is research we conducted together. So I'm a little maybe over-optimistic on the practicality of this, but it works for us. So it's feasible.
When you say over-optimistic on the practicality, what do you mean by that?
Well, you need the machine, you need the time, and you need the room. So it's not, look at the primary care office. There's not always a room where you can actually have somebody lie down. You have to really make it work and maybe take people somewhere, have them rest. I had a lot of discussions on the practical side around the value of FibroScan. If somebody lays down and you measure immediately, you have to adapt to a certain, heart rate. And then so you should have 3 minutes at least, maybe better 5, but 3 minutes wait before you get the scan. And that might not be as easy if you operate outside an expert center. So, and then of course you have to pay for a machine to bring it there. You have to pay for the person that goes there. But if you do that, you find a lot of disease. And from that, I think there was a thought emerging that we could actually do some initiatives where we take the machine into different settings, like put them in a little liver bus and go on a ride and kind of go to people and have them scanned if they want it in different settings, even outside the medical system.
I'm told there's a company in the UK that does that. Louise, would you know anything about those people?
Oh, I might just know exactly who those people are. But I think when we start to think outside of the medical framework, we can be very, very innovative. But we are very trapped by concrete thinking. It's got to go through this, and this. We've got to do it ourselves. It took me 12 years with my team to establish the largest FibroScan service in the UK but I never had somebody employed for FibroScan. I always took a piece of somebody's job plan to do that because it was never fully funded. That's probably a broader conversation than the meeting, but I think Jörn is absolutely correct. What we can do is get it out to people in a way that is very innovative and get it into community, get it for hepatitis C, get it for all communities, because everybody has a liver. Pick the liver at risk to find out the cause. So we don't stigmatise on what your liver damage is by your FibroScan. And that's the key. A lot of people talk about stigma. They don't want to sit in the same rooms as people with different liver diseases. They all have a liver disease, but we self-stigmatise. And I think that it is one thing that machine goes beyond. It does not. It just tells you some information, and then you can have conversations, and that removes stigma. And I think that's a big part of being able to get these machines out in the way that Jörn's describing and that Jeff has alluded to earlier.
I think that's a great bridge into this whole idea of preventive hepatology, which I want to spend a little time on because I thought there was some dynamic around that at the meeting I found fascinating. So would that be preventive hepatology, getting a FibroScan on a bus, or would that be like a whole different thing?
For me, it is.
Yeah, it is, but because you have to recognize somebody before you do prevention. You can act based on obesity or metabolic risk factors, but that should be happening, at a different level. I think the hepatologist field can bring in patients or address the patients and then offer specific interventions that have shown liver protective effects at that level.
If I could add to that, when preventative hepatology, when the landmark review came out in 2008, it was titled Minimizing Symptoms and Optimizing Care. What I've been trying to do is take us back a step, go more upstream, and think more about how we actually prevent the need for that care. This is about early identification, but it's also about actual primary prevention. We've had these same discussions in HIV, and I know it's been a big challenge in preventive cardiology, but we need to rethink this. And of course, hepatologists might ask, well, what's their role? And that's fine. We're expanding the community of practice, just like in HIV and hepatitis C. It used to be the infectious disease doctor. Now it's also the addiction doctor. It's also the nurse. It's also the peer. That's how we've been able to work towards ending that. And it's got to be the same thing with fatty liver disease. It's not just onward progression to NASH or liver cancer. It's not getting NAFLD in the first place. It's doing everything we can so we can identify it early on and reverse it.
So, Jeff, that was one of the tension points that I heard, is that preventative hepatology does not begin with the hepatologist, right?
That's right. It depends where you are on the continuum. So preventive hepatology, I realize it raises issues because it goes back to, well, what about social nutrition and food systems and the built environment and urban green spaces? But that's why all member states of the UN have committed to the Sustainable Development Goals. So we want to make the world a better, safer, healthier place, and hepatologists can speak to what happens when we don't, so they contribute to that. But then if you are diagnosed, preventative hepatology is getting diagnosed early, getting the HCC screening you need, making sure patients are aware of their fibrosis stage. In our study with Patricia Carrieri, we found a large number of patients didn't know their fibrosis stage, yet those who did were more likely to adhere to lifestyle changes. So, this preventative hepatology is for everybody, and it means we can include other fields in it. It doesn't just belong to hepatology. We're not going to end, or at least reduce the increase or stance the increase of fatty liver disease just from hepatology.
I was just going to say, I think the idea of preventative hepatology is fantastic, which is why I now focus more on liver wellness. And I think it depends how early you go. If we say that fatty liver is accountable for up to 70% of those who have type 2 diabetes or present in, the same with hypertension, the same with high cholesterol, and we ignore just the liver side of it, by making it preventative hepatology, we make it preventative ill health, because we find it that much earlier. And finding it earlier and upstream, as you detail, actually gives us opportunities to not just prevent hepatology, we prevent cardiac disease, we prevent diabetes, and we educate at an earlier stage. And I think that has value when we talk about, is it cost effective to screen for liver disease? No, it's not. But it is potentially cost effective to screen for something that accounts for a third of all of our adult populations, and we are not screening for it. How do we not, in today's societies, screen for something that affects over 1/3 of our adult population and say that it's not within the interest of healthcare to do so? So it's a reversal of that question. And preventative hepatology has certainly for me, is all encompassing. It's body health. It's about that balance and that equilibrium that runs around the liver. And we then prevent liver disease and assist in the endocrinology, cardiology paradigms that are associated. And I think that's what, for me, taking away from that is.
That was part of my parse, so thanks. I don't have to explain that part. I can go on the other part. Part of the parse is that what we call preventative, the first part, Jeff, of what you call preventative hepatology, which is what Louise was just describing, what you termed it, is really about preventative metabolic health. I mean, metabolic health plays out in a whole bunch of different ways. This being one of them, it's, to use Stephen Harrison's phrase, this is a canary in the coal mine. But really what we're trying to do is we're trying to trying to improve health in the coal mine, not just worry about the canary. So that's interesting. And when Zober made the point about all the problems of preventative cardiology, I think it speaks to that point. You really can't start preventing at that point. You have to start preventing earlier and more broadly if prevention is the goal, whatever we call it. Now, what you described going on in the hepatology office in terms of being more aggressive and faster about letting people know what they've got and what they can do about it almost struck me as more of a, pardon me, kind of a proactive hepatology, if you will. Hit it earlier, hit it harder. But there you're talking to people where it's already too late to prevent the problem. A problem exists. Now you're trying to prevent the sequelae and maybe regress the problem. But that feels to me a little different in terms of nomenclature than Louise was talking about. And I think that piece of confusion might make the task harder when you bring it to a broader audience. But that was just the reaction I had listening on Friday afternoon.
I agree. And I put forward the idea of that session to start this conversation happening. The way I'm trying to illustrate it is essentially a continuum, and we would almost have planetary health, the earth there and the food systems, and talk about who's going to do what to make sure that we eat healthier and we can exercise more. And eventually you move along that continuum, and at some point you're in the hepatology office and you have NAFLD, and that's when preventative hepatology is in the hands of the hepatologists. We want to make sure that, as few people as possible get there unless they need to, but we need to recognize that we're not going to resolve this issue by just helping people not get NASH or HCC. The vast majority of people with fatty liver disease are undiagnosed, and it's ubiquitous now with over 1 in 3 adults.
So Ken Kusi talks in our other podcast about the idea of creating a world of endohepatologists and hepatoendocrinologists. So when Naeem talked about being more comfortable with GLP-1s, for example, that would be a definition of what Ken would describe as an endohepatologist.
Sure.
Right? That you're looking for diabetes also, and you're crossing that boundary. Jörn's talked about that a bunch on the podcast, not in that word, but that kind of thing. In exchange, getting endocrinologists more familiar with fatty liver and how to treat. That all makes tremendous sense, right?
Roger, it makes sense, but from the view of the medical system, we're thinking in those silos that we're all aware of. So the hepatology treats liver disease and might not look so much outside. So I think this is something, and that brings us back to the main idea or the overarching aim of INCBCN. We bring these disciplines together. We want to do prevention, maintaining health, and of course liver focus, because that's I can only speak I am good at. But of course I want to be opening up and interact with all these disciplines. So I think it's a patient-centric view of the future, how we provide health.
It makes sense. And I think you're right. I think systems tend to be recalcitrant or calcified. Pick the calc of your choice. But the aim is important, and that the goal makes tons of sense. Let's go on to the endocrinology session, which I thought was fascinating.
I'll just start, and Jörn, please weigh in. Ken Kusi put this together for obvious reasons, and having the head of the Spanish Society, who's based in Pamplona, as well as 2 leading endocrinologists in Barcelona, I was concerned that maybe it would be too Spanish specific. Would this be interesting for the audience? And I was really impressed. I mean, everyone really appreciated understanding the Spanish system and also seeing the examples of what they're doing and how these endocrinologists are really focused on fatty liver disease. So next year, we want to expand that, make it more international, but I thought it was a great way to start. And I thought they were all 3 were great speakers, very engaging, very interesting.
And again, very practical view on how in an endocrinologist clinic you implement this. What's the disease burden? I think it's the way forward, how we want to interact and learn from each other. Last year we had a nurses section. Louise was there. This year we try to get the endocrinologists more on stage. And I think moving forward, primary care would be great to have. They're more difficult to engage with, but I think that's the way we can build it and expand the thought of liver health and preventative hepatology in multiple disciplines or across multiple disciplines.
I kind of thought that last year there was some primary care there. I mean, John Dillon, for example, talking about ILFT.
Oh, yeah, we had this year, but, I think even more like a full session, and that's why I think made this session so special. It was led by an endocrinologist. We had 3 endocrinologists speaker, and they were discussing fatty liver disease as part of their work schedule and clinics, and that was just a different perspective than what we normally get.
I thought they were all great. I thought Nuria in particular, I gleaned a lot from, but I think all 3 were fantastic. I couldn't agree more. In the interest of time, knowing that we lose Jeff in 17 minutes, I want to jump past the patient organizing session with a brief comment from you folks if you want to, and then I want to move on to the next day.
I would just add that, as always, it was good to hear from the patients. Alina Allen was chairing, and she asked very directly in response to, I guess, maybe a small debate going on in liver Twitter, should people be diagnosed earlier and do the harms outweigh the benefits? And the speaker, the patient was very adamant that people have a right to know, they want to know, and it gives them the opportunity to do something about it. They should not wait until they're in more of an advanced stage. It's similar to a discussion I had a couple months ago where those with F1 were referred to as having a healthy liver. I understand how that could be seen from a hepatologist, but we had these discussions with hepatitis C here in Copenhagen at the University Hospital, where I was told, you don't have an F3 or F4, this is maybe 6-7 years ago, you shouldn't be treated. People live with viruses all the time, and Denmark ended up being one of the last countries in Europe to remove their reimbursement restrictions. They were hugely mistaken for so many reasons, including onward transmission. And it's the same thing. We've heard it from the patients. We know that people should be diagnosed early, provided the information they need so they can do something about it. Most of them, we know, will be overweight. They may have diabetes, so they will be in care. They will have other issues going on, and they should be aware of this. We shouldn't be keeping it a secret from them, as some hepatologists have been proposing lately.
Point well taken, and I think really important. Remembering that we're coming a week after the FDA in the U.S. shot down beta-cholic acid, which, as Jörn pointed out when we discussed this on podcast, denied hepatologists the chance to sit with patients and say, I have an option for you.
I think they have a lot of options. They just don't have a specific NASH drug. I mean, they have to then think out of the box. So what about nutrition? What about lifestyle? And what can they do to do a better job at getting patients to adhere to lifestyle interventions? It's a big setback for the field, but there's still things people can do. We are where we are.
Yeah, I agree with that. And I think actually that there are things about that committee that suggested that we're not going to be there that long, that if they thought the efficacy guidepost was good enough, and I think Jörn heard that, I heard that, others heard that, then a drug with a better safety profile should do better. And in theory, at least, we have one of those coming in the next several months. So we'll see how that plays out. I want to move to the next morning because I thought that first session, which I wasn't sure whether I was hearing or dreaming because it was 3:00 in the morning in the States, and I was awake but slightly fading in and out.
Roger, let me just comment with something we had on the last day, and we put it a little bit to the end, was of course the posters. So this is not a session where you send a lot of abstracts, but I felt the ones we had were presented well. There was a woman from Libya, actually, a physician who trained in Spain, and I exchanged on her with her fatty liver program. She said she had NITs using in her clinic. So I found that was really fascinating too. It was about getting younger people. I had some from my team present some of the data in addition to what's been sort of presented as an oral presentation. So clearly the posters sometimes come too short, but the people that were attending were really engaged, and that was also a good opportunity for younger folks.
As we discussed last week, I'm a big fan of poster sessions. So that's a good point to have made. Is there ways for people who did not attend the meeting to get access to any to what's in the posters and to any of the commentary around them?
We have the program book with the abstracts online. The posters per se not online posted. Maybe something to take into the future.
Maybe an important note, and I thought a couple of those posters, I did not get to obviously hear any of them described, but I was looking at them Friday afternoon when I was completely compos mentis because it wasn't 3 a.m. And I thought some of them were really pretty spectacular. All right, so going to Saturday morning, first session, diagnostics.
I think the theme of that morning, which was kicked off by Dr. Alina Allen at the Mayo Clinic, was, are we going to be able to use artificial intelligence to diagnose? Can we get the kinds of profiles analyzed? What are the advantages of AI over logistic regression studies? So, she really walked us through what was meant by AI, which has been around for a long time, as she reminded us, from the 1950s, but how we need to really give this a think in terms of diagnostics. I don't know if Jörn wants to comment on that or on Dr. Mazen Nuruddin's entertaining session, her talk that came just after that.
Alina was great. Let's summarize her talk up. Something we went through discussing afterwards was that the quality of the data that goes into these algorithms is critical. And I think the way physicians write notes are very practical in the clinical everyday's work, but it's not fit for, exploration by AI at all levels. So I think also one learning from me was that if we want to exploit that and use it to a bigger extent, we probably need more standardized terms. Now imagine that we change the name and the machine doesn't link those entities anymore, right? So the machine is going to learn, that's for sure. But anyway, so one of my take-home messages was here that we need to also be very careful how we enter the data for the machine to be used perfectly in algorithms. Mazen went on, and I think he did a perfect job. He had a little bit of a humoristic side, linking this to the urgent need to actually loop in celebrities and kind of be a stakeholder for the NASH community community to come out and talk about NASH. I felt like he had indicated me being one of those celebrities, but then he went back to somebody from the movies, and I think we're trying to get him on board for next year.
The celebrity?
That would be Matt Damon. I'm sure Matt's
I was going to say, was that Matt Damon a chance?
I think that's what it was, yes. He did a great job.
I'm shocked that Malcolm would talk about you and Matt Damon in the same breath publicly.
The other thing,
not like it's never happened.
The other thing he pulled out was, of course, a young Lazarus who did elegantly did an online recording for raising awareness, and I believe it was HIV, Jeff. And it also reminded us that we really have to, at multiple levels, step up and really bring out the word about this disease and advanced disease. And actually, social media, as Jeff does so well, is one of the momentums here.
Yeah, he found an old video from 2007 when I gave the first talk in Europe in the community about hepatitis C. It was with the Correlation Network, and he caught me on the second round when after I was done with the interview, the community group mentioned that they had forgot to turn on the camera. So then we did the whole thing again. So that was that interview where we were telling them about hepatitis C, since they were so focused on HIV and realizing that as antiretroviral therapy became available to people who injected drugs, they had to address their hepatitis C or they would have another set of problems.
James Joyce once famously said about the novel Finnegan's Wake, the first page took me 17 years to write, as you take you a lifetime to read it. This is going to be the Cliff's Notes version of 17 years of Finnegan's Wake. We've got 10 minutes for you folks to cover what you think were the high points of Saturday. And I might have a question at the end of that if we have time. So what on Saturday do you think were the most important things that happened in what was really an action-filled day?
Oh, there's more to come. And again, we're short on time. We had Dr. Elena Sina speak on, give an oral short abstract presentation. She's part of the EO Pearl initiative, which is an EU-funded consortium developing a patient-centric collaborative research platform, which I thought was great, and I hope we're going to hear more. Clearly, one of the highlights was the lifestyle intervention NAFLD treatment and care session, and we had a pro and con proposition for curing NAFLD by being vegetarian. Shira Salvasaji, who's well known for all his strong work around the impact of red meat, did very well presenting. She was proposed against the position by Camilla Dalby Hansen, who's done a great job, and actually a clinical trial with liver biopsy confirming that high-fat, low-carb isn't actually, or is also an alternative to staying totally meat-free. I felt there was a lot of Twitter discussions around this, so we were successful in reaching out and getting people that weren't even attending, commenting on these sessions, so that was great. Stephen gave a wrap-up on the available medical therapies, and then we had additionally 2 presentations, both given by Italian fellows, actually, discussing time-restricted feeding and social jet lag, which is kind of a new concept for me. So that was part of the abstracts we selected before all presentations. I felt that was a very strong session. I'm not sure, Jeff, you have anything to add?
It was. I think, Roger, having a debate was just great. They were both amazing. They were very convincing. They used a lot of evidence. And I think that's what we need is open debates. Next year we can do some voting pad, anonymous voting about it. But, it was really great to discuss these issues in a debate format. After that session, we moved into talking about inequities, what some call disparities in fatty liver disease care, both for women, but for those of lower socioeconomic status, minorities, and others. Patricia Carrieri and Juanma Periquez both made really nice presentations because we don't address this enough. We need to remember, even as we scale up diagnosis and get people aware of their fatty liver disease status and into clinics and hospitals, we're going to leave the poorest behind once again, and they're the most affected. So that goes back to what I said earlier about thinking about the entire development and health agenda and why we need preventive hepatology before you get to the hepatology units, because many people are not going to get there. And we attested to that the next day when we took our clinic, as we do every weekend, into the community where people really don't go to the health system unless it's an acute situation. And we're finding 10% hepatitis B positivity in that population. Now we've tested over 1,000 people over the last couple of years. We then had a closing session about what it's going to take to drive the field forward. Camila was back on the stage, joined by Ken Kuzi and others. And we, and really, I'd say the whole audience was on the stage because everyone was, discussing, and that's been a hallmark of having a small meeting, is that everyone's been there the whole time and they're discussing. So we really talked about, 6 or 7 key issues to drive the field forward. It was pretty obvious, and I tried to limit the discussion because we all agree that we need to resolve the nomenclature issue, adopt the new nomenclature that was agreed on by a majority, and I know it's been discussed here on Surfing the NASH Tsunami. But then we talked about, what are the other things we can do? The importance of multidisciplinarity teams, how to engage people early on, and a whole range of issues.
So, Jeff, slightly counterintuitive point. Listening to that discussion, I wondered whether that made it easier for the name change or harder for the name change. And here's where I'm going. If you go back to where we were 20 minutes ago in this conversation around preventative hepatology, the name change makes it easier for everybody in hepatology to get aligned, but might make it harder to explain to people outside hepatology what we're talking about, simply because it's a more cumbersome structure with more big words. I know when I look at that as someone who's looking for precision, I love it. And when I look at that as somebody who's looking for communication and simple explanation, I wonder how easy that's going to be to do. And I had a similar reaction listening to that discussion.
Jeff is very intimately into the whole process and also the technical aspects. If I see it right, you need, and I'll let you have the last word on this, Jeff, but you need an overarching theme that unifies certain things, and then you might need some granularity to actually subdivide aspects that we're not 100% sure yet we've got right, but that offers the specialities a way forward to differentiate certain disease phenotypes.
I would just add that some people will go on using the terminology that we have now. They'll call it fatty liver disease, and for them it will be important to say that it's not alcohol related, so that it's non-alcoholic fatty liver disease. That's fine. As we report it for reimbursement when it's listed in ICD, it will be with the new terminology. But those who earlier proposed that it's metabolic associated have done us a great service, and that's the new name. I mean, that was already shared at AASLD in the autumn and again at DDW. So it's metabolic associated steatotic liver disease. For those who are talking about alcohol or fat, even if it's fatty liver disease is problematic, they have an alternative now, which they can just come home and say, I have SLD, it's a liver disease, and this is what I need to do. So I think it serves both sides. It's not a Taliban approach that you have to use that name every time you talk. In fact, we'll find ourselves explaining SLD by talking about excess fat in the liver. So we're not going to avoid it entirely, but it gives you the opportunity to basically go back and say, this is what I have, if using that terminology doesn't work in your community.
What's so interesting about this whole discussion is that when we start rolling it out to the world, we're going to learn a lot that y'all got right, and we're going to learn a couple of things that didn't work the way people would have predicted, and then we'll have to figure out what to do about that as we go along. That's not in any way to belittle the process, which I thought had a tremendous amount of work done by a lot of people, well-intentioned, and I'm not sure you could have come to a better answer, frankly, given the path that everybody chose to go down.
Well, like I said, that was a very small part of the discussions. We really wanted to talk about how to drive the field forward, what needs to be done. And there was great agreement, as expected, on the important role of non-invasive tests, making them more easily accessible, making more people aware of their fatty liver disease, of engaging more with endocrinologists, engaging more with GPs, engaging more with patients and the community. So that kind of came to the fore in this meeting that's, different than many others, that state-of-the-art talks, but then really state-of-the-art discussions where, we had people who knew very little about fatty liver disease in the field, in the audience asking questions, and we had the leading experts in the world also asking questions. So it was fascinating.
Two closing questions. Number one, anything you heard from the audience in the meeting that really surprised you?
For me, it wasn't a surprise because I've spoken with Chris Kopka before, who I've known a long time, but he gave a very nice car analogy and said, really, a lot of the safety on the road is because cars have been made to be more safe.
Yeah, that was great.
And it reminded me, or reminded all of us, that some people will change their behaviors, but as any hepatologist will tell you, and nutritionists, it's hard to get that behavior change. That's also why we want drugs to be available for those who have that challenge. And so what really his analogy was we need to make food safer. We need to change what people are eating so you can, I added on to that, the example of a colleague I worked with, Scott Ratson, who went to Anheuser-Busch and worked with reducing the amount of alcohol in beer so people could still keep drinking when they watched their sports, but there was a little less alcohol in it. And so what Chris was getting at was, can we get rid of the ultra-processed foods? And for those who are not really going to change their eating habits, can we make some of that food healthier? And so I like that, how we start to change the structures and systems. It's challenging, but it would make a big change very quickly. And I think that took some people by surprise.
Jörn, anything you found surprising coming from the audience or in the meeting itself?
It took me by surprise, and it's that insight, from people that have been working in public health or in general aspects. I'm always so focused on the liver side of things, and it's really a nice thing about INCBCN is that it helps me look up from my little dish and see the entire table.
Yeah, that's an interesting way to put it. I have to agree. I thought the metaphor about cars was probably the most out-of-the-box thing I heard in the entire meeting, and I had the same reaction. I said, boy, that's smart. A lot of medicine is about what we ask the patient to do as compared to what situations we put the patient in where she or they are more likely to succeed. Second question, what will be different next year? To the degree you can figure that out yet?
Well, we may have the same venue. It will be in Barcelona again. Hopefully we'll have a surprise. So I can't tell you what that is. That'll be different. But I think, we'll expand the endocrinology session, as I mentioned, and go more international with it. We're discussing a possible call to action to launch. So more on that when we get further along. And we want to engage more with primary care, and we want to figure out how to make the NIT session, both the lectures, but also the hands-on session, even more engaging, so we can really try out more types of tests.
Fantastic. Jörn, from your perspective, anything not in the either if not in the program, then simply in the way the meeting feels or the feel, form, function of it?
For sure, we aim to keep the diversity up and involve younger folks and get, the hands-on experience of doing liver exams and taking it out to different areas. I think that's something we want to maintain and build on.
We also are discussing, it's only about 72 hours since the meeting. We did have one meeting, but about next year, but we'll pick up on that in a couple of weeks. But also maybe having a young investigator session for an hour and talk about, their priorities. As the drugs advance and are in early phases, we need to think about the next generation. And we've been talking to some young people, some who spoke in this edition of INCBCN, but maybe having them drive a session and hear from them what their priorities are. So we're going to get more engagement, expand the steering committee, expand the scientific committee, and start to listen to more people so that, it's a responsive meeting to what people feel the field needs.
That's very cool. That's a great note. Louise, any questions, comments? Other than next year, maybe you and I will both find a way to be there, which would be a good thing.
Yeah, I'm just excited to see where it goes. We're closer to drugs now. Although we've been turned down for obeticholic acid, we are closer to drugs to be able to offer our patients, but we're not closer to the education that's needed in the medical, nursing and allied health fields. So we have a big problem that if we don't start to address the education at those levels, it doesn't matter how many drugs we have, we cannot educate patients. To some extent, the nomenclature may or may not assist that, because I think the one thing that allied health are particularly good at, and nurses, is being able to put it in the language of the person in front of you and using analogies and making the diagnosis and the discussion very visual and informative in a way that somebody can understand. But we do need the concept of where it's coming from, where it's going to, and how we can assist in that. But it cannot just be dumped on allied health at the end. So these pathways have to be taking in the lack of resources that we've currently got, and how do we maximize the resources that we've got with the ability to put it in, because we are talking about arguably one of the biggest health challenges with new medication to get it out there into those populations, but also the education that we've alluded to earlier about being able to educate upstream when we find poor liver health that drives other diseases, or other diseases that drive poor liver health. So that is a massive conversation to have, and it is certainly an area that is considerably lacking in any planning that I've seen. So I'd like to see some planning of how that can be looked at, because we've got some great discussions coming out of the last two meetings. Let's put some practicalities into making those in a pathway of that sort of nature.
I couldn't agree with you more, Louise. And one of the organizing committee members was stressing how we should really focus on pathways, a whole range of pathways, exactly what you're saying, in line with our discussions on expanding the community of practice and expanding the models of care. We need to look at each pathway. What's it going to take to have an efficient pathway in endocrinology, in GP services? And we talk about GP services as if it's one thing, but they're so contextualized by country within countries and different cities that we're going to need to think of really dozens and dozens of pathways with little tweaks. Sometimes you'll need a peer to help you get there. Sometimes you'll have to go to the community. Sometimes someone will just walk in and have their test automatically ordered, FIB4, like with Javier Crespo in Cantabria, or through, the iLift with John Dillon and company. But we're going to have to think about all of these different pathways. So I think that's going to be a big focus next year as well.
Well, that'll be exciting. That'll really be exciting. And by next year, ideally, we should have at least one drug, which would put a whole different spin on all this. Jeff, thank you for coming to us so quickly after this meeting and so early into your recovery process. And Jörn, as always, Jörn will not be with us next week, but Louise will be. We're looking at a couple of different ideas for the meeting, but whatever it is, it will be cool. And then next Thursday, we will be back with something around International NASH Day, which I'll tell you more about next week. So thanks to you folks. I'll be back with Business Report in a couple of minutes. Let's all say goodbye.
Bye. Great to see you. Bye.
Bye-bye.
We'll see you.
Thanks so much.
Thank you. Bye-bye.
And now for the Season 4, Episode 24 Business Report.
Slava Ukraini, Heroyam Slava, glory to Ukraine, glory to heroes. This week, we recorded the episode on Tuesday because yesterday was Memorial Day. As I stopped yesterday to think of those brave men and women who sacrificed their all to defend freedom here and around the world, I thought of the greater proportionate losses sustained by Ukrainians. Now, they don't have a choice. They're fighting for their homes in their homeland against a savage attack, whereas we have not fought on U.S. soil in any significant numbers since the Civil War 160 years ago. Nonetheless, the raw courage and tenacity shown by the Ukrainians every day should be an inspiration to us all, and certainly all of us who believe in freedom. Slava Ukraini.
Our month of events starts next week.
Our June is a month featuring and celebrating events, starting with International NASH Day next week, proceeding to previews of EASL, which is part 2 of 2 with Stephen Harrison and Amal Khoury, followed by a preview of ADA, and then coverage of those events themselves. This will take us through June and into mid-July. Please note, next week's episode will not post on Wednesday night. It will post on Thursday night at the conclusion of International NASH Day.
Jake's last month in Kansas starts Thursday.
For those who didn't know, our associate producer, Jake Norman, is a joint U.S.-New Zealand national who's lived in Wichita, Kansas for the last several years, the last few with his partner, Sophia. Jake and Sophia have decided to put down roots in a place more convivial to her work and closer to home, and they've settled on Melbourne, Australia. Jake leaves at the end of June and should be set up in Oz right after the 4th of July, a day that means little or nothing in that corner of the world. Now, Jake will continue to provide his superb editing and other support services from the other side of the world, and one day when Louise is in Perth, we'll have to bring him on for at least part of an episode on fatty liver in Australia. We wish him well in his travels, and I personally feel fortunate to be living at a time when Jake can keep working with us from 12 hours away, more or less, depending on the time of year.
This week's Vault Conversation looks back at innovations in NAFLD Care Year 1.
This week's Vault episode comes from our coverage of innovations in NAFLD Care Barcelona 1 last May. As timing would have it, last year's recap episode was also episode 24, although it happened earlier in May than this year. So this is season 3, episode 24.1. It asks and attempts to answer the question, did the innovations in NAFLD Care conference strengthen the case for integrated pathways? By now you know the answer, but the conversation includes some interesting points and a lot of laughter, so enjoy it. And with that, I'm off until after International NASH Day. Thanks to Jeff, Jörn, and Louise for a great conversation today. And to Jake, Magic Mike, Steve, and Eric for helping get this episode out the door. Enjoy International NASH Day however you celebrate it. Remember to let us know how you feel about Rising Tide and send reviews. And of course, stay safe, surf on. We'll see you next week after International NASH Day on the podcast. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.